me today. We're going to spend a few minutes going through some of the GW experience with responding to COVID from the perspective of emergency medicine. And a lot of the work that we do in emergency medicine is obviously frontline response, but we're going to talk about kind of some of the considerations we had to make as the pandemic evolved, and as well as some of the technology that we implemented, including telehealth in response. So this is kind of our short agenda here, and I'll just kind of get through it. And I'd love to have a dialogue with you all and try to answer questions as we go, or at the end as our moderator dictates. So we started to anticipate the needs to prepare and build capacity within our workforce as we started to hear really scary reports coming out of Italy in February. And I think a lot of us were in that situation. So a couple of the interesting things from an emergency response perspective that we started doing were looking at what capacity we had. And we were fortunate to have actually a large capacity of EMTs, paramedics, and other healthcare personnel who work with us when we were staffing large scale events like mass gatherings on the mall, inauguration events, parades, and other events in the city. So we had a cadre of people, and we knew that there were some regulatory barriers to being able to leverage them in the maximal way. So one of the first things we did was actually work with DC EMS and emergency response to see if we could develop new protocols that would allow this workforce to contribute to collecting swabs, the nasopharyngeal swabs, the deep swabs for COVID testing, and then eventually be able to administer vaccines. Neither of these activities were in the typical scope of practice. And so kind of an early event that from a policy and regulatory perspective, that was important in the response. In conjunction with that, we had to develop donning and doffing protocols for PPE, because if we didn't protect our workforce, then we wouldn't have a workforce for long. So we developed a training and certification program. And then as we developed this PPE program, we also recognized the fact that PPE burn was a huge issue in all aspects of our response, whether it was in the community or within the clinic or the hospital. And so that's where we started to implement some telehealth. In between that, I'll just mention that we also anticipated a large demand for credible COVID-related information. And that information needed to reach the public in an efficient way. It needed to have local leadership and local brand recognition. And it needed to be able to provide the community the support that it was looking for, especially in those early days when there was a lot of confusion. So these two images show what was the result of our pitch to the city to launch a COVID-19 call center, a 24/7 call center staffed by EMTs, paramedics, medical students, a number of our GW-based community who could answer resident questions. And they could do a couple things. One was answer general queries, and then the second was to conduct kind of a pre-screening that could lead a resident into a telehealth encounter that would allow them to then either get the medical care they needed or get a test. And we were able to leverage some of the existing technologies that we had in place. We had a low-code database that we were easily able to build kind of algorithms, because we were bringing a lot of people together and we needed to have a uniform and unified response. And so building scripting, data collection tools, reporting tools was the way that we were able to manage that rapidly growing workforce. And then we were also very careful to make sure that patients got to where they needed to be. And what I mean by that is, we are one of 8 hospitals within the small area of the District of Columbia. We have great relationships with the federally qualified health centers like Unity Healthcare. And of course, we have to maintain appropriate relationships and help patients retain appropriate relationships with their primary care provider. And so we were careful to make sure that when patients came through kind of the DC call center, it was branded appropriately, a DC DC health-based call center, just powered by GW, and that we were not kind of stealing patients, if it were. It's very important that people it was very critical for us to make sure that patients got to the doctor they had an existing relationship with, if at all possible. We also needed to shift to a mobile, well-trained, and expanded workforce as related to COVID. So thinking about testing, it was a critical constraint that was required in this response, so we could identify disease, understand, identify the burden of disease, and predict where that disease was going to impact our city and our other medical resources. And so some of those responses included things like at-home testing for persons of interest. So if someone did require testing at home, we could send a team right to their doorstep, and that eliminated them spreading disease into the community. Walk-up testing. We developed a tent on our campus that helped with the initial demand for testing. Also, the idea of using tents and drive-throughs was important because it helps to keep clinical areas clean and preventing spread within a clinical area. There was a huge demand, obviously, in our most vulnerable populations in the nursing homes. So we were sending teams out to nursing facilities. And interestingly, one of the insights that came from that is that the healthcare worker cadre that works in skilled nursing facilities often work in multiple facilities in a given week. And so this was an opportunity for us to pick up on the fact that disease could transmit from one healthcare facility to another because of these cross-working personnel. And so frequent testing was a really critical part of that response. We have a large telehealth practice to the maritime industry, and cargo still needed to be transported. So there were a number of protocols we helped develop around pre-testing, quarantine before crew boarded ships, and then if there were outbreaks, how to manage those. And so we were actually able to, because we built this infrastructure, deploy teams out to ports. Think of DC as landlocked, so we don't have a port in DC, but many of our large clients will ship out of Baltimore or Norfolk or sites in Florida. And we were able to send our teams there to do testing. And where there wasn't testing in some of these communities, we actually were able to bring those samples back to GW Hospital and do rapid turnaround. Especially when you saw the response around the national labs like LabCorp and Quest getting backed up at periods of time of high load. Being able to offload that to a local lab and have rapid turnaround times was a very important component. And where we've shifted some of our response now, which includes testing and strategies for appropriate testing, but also protocol development, training, is reopening support. So I'm going to jump back now to that PPE conversation, and it was a really major challenge, and we're fortunate again at GW that PPE availability has now become close to meeting our needs and is not in as short supply. But early on, we were very concerned about this. The supply chains were in question, and we were able to use telehealth and video technologies enabled by waivers from CMS in response to pandemic that reduced restrictions on how you could practice telehealth, that allowed us to use telehealth right within the hospital. So we were all in the same building, but we were still using video because we wanted to preserve PPE. So in an academic center where you might have a large care team of learners plus supervising faculty, if all, as you see on TV, right, if all 5 of us went into a room and discussed a case like House, we would burn 5 pairs of PPE. And we were able to now, just put one person in PPE, allow that person to have an iPad on a stand within that room and have the rest of the care team be on video outside the room without having to burn that PPE, but still be able to contribute to the care, still get that in-person examination, the complete examination that sometimes is limited in telehealth. And I think there was some interesting downstream effects of that. One, it was patients had high levels of satisfaction, very much appreciated the reason that we were doing it and didn't have many concerns about it. But 2, it gave us an opportunity to kind of flip the script, as it were, from a teaching perspective, where often a learner goes in to see a patient, presents the patient to a teacher, and the teacher gives them feedback, but there's not this kind of simultaneous observation period. And so we were able to observe a junior, doctor, present, resident, or other student do this, provide the service in real time and give them feedback. And we could do the reverse, where the learner can now observe the attending or the teacher doing the same function. And I think that was actually beneficial. One of the picture on the other side here, in hospital telehealth, also allowed us to use our specialists who may be within the wards caring for patients who would normally respond in person to the emergency department for a stroke code or a heart attack or some other type of activation. But now they could work collaboratively with us because we're already taking care of that patient in person. We could bring them in by video to get their expertise. So another mechanism to help preserve PPE. This slide highlights really an extension of using technology for discharged patients at home. So we use what's called remote patient monitoring or biometric monitoring, which is, I would say, another form of telehealth, but we are careful because it's not bound by some of the restrictions, regulatory restrictions of telehealth, like licensure that may be encountered for telehealth services. But we were able to discharge patients who we thought were stable home with a thermometer and a pulse oximeter to measure their oxygen saturations at home. The reason this is not utilized as much pre-pandemic is because, for many diseases, we have a good sense of the prognosis. We understand kind of the natural course of that disease process. But something novel like SARS-CoV-2, we don't have as good an idea of what might happen. And we know that this disease, has an asymptomatic component. It can have a very strange manifestation of a person not feeling very short of breath, but having dangerously low oxygen levels. So utilizing this type of technology to provide data from home could allow us to have early interventions. And so we did a combination of providing the technology, which they took home, providing a daily questionnaire via email and a secure link where they could send us their symptoms, marrying that information together in our 24/7 telehealth command center, where an EMT could look at that data on a daily basis. And here you can see just an example or an illustration of how that data came into our system. And then we again leverage that same very simple technology to help percolate up to the top those cases that might be having an issue based on thresholds. And then if that patient, didn't meet a threshold, like their heart rate was too high, their oxygen was too low, or their symptoms were worsening, that could trigger a call by our operator to see how that person was doing. And if the operator was concerned, then could escalate that patient into a telehealth encounter or back into the ED if needed. We also wanted to follow that at kind of a population level, so we could see what the demands were on our monitoring team. And really what we learned, at least in April and May, kind of the height of demand in DC, was that this was a very high intensity program. It took a lot of resources to manage even a relatively small number of patients because sometimes the data wasn't good, sometimes the patients did not respond, and a lot of patients had a lot of questions. But I think we were able to build this sense of connection with the healthcare system. We were able to build a confidence in care, this kind of security blanket for patients. And so we're very excited about how this might be something that we can move forward as a take-home lesson from COVID that might be implemented into other use cases. So I'm going to transition here to what is more traditional telemedicine, video encounters. We were driven early on in March by the need for social distancing and keeping our highly vulnerable patient population outside of our clinic. And also the demand of lockdowns and limited mobility of people from their homes. So we rapidly brought the whole GW practice online for telehealth. And we really had a very limited telehealth practice within the organization limited to the Department of Emergency Medicine doing maritime aviation and other telehealth services I've kind of alluded to earlier. And here we brought on over 500 physicians from all different specialties, you think about a primary care doctor, a specialist, or a surgeon to be able to continue to practice, continue to provide care in the community through telehealth. And to do that, we had to develop the capacity from a technology perspective. Did we have the server capacity? Did people have devices? Do we have enough webcams and headsets and those types of kind of essential pieces of technology that really, in a very high touch, in-person academic environment was not readily available. And so we had to tackle that with a bring your own device approach, allowing people to work from home, but trying to kind of do our best to support them with what they had until we could make them whole. And there was a lot of demand for initially kind of COVID screening, routine care. If you got patients with high blood pressure who need refills, or diabetes, and all the types of chronic diseases that require routine care, and those with immune compromise who needed to reach out to their specialist, like a rheumatologist or an immunologist or allergist. And also supporting dialysis, which had to continue on as well. But I think what's interesting on this slide is it kind of shows you this incredible growth, and you'll see this, this is a small scale version of going basically from 0 to 800. So 800% growth of telehealth services over just 60 days. This is mirrored across the country in organizations, small and large. And I think what's also interesting is, one of the challenges to medical practice is this metric I've circled here called the no-show rate. So this is where you have someone on your schedule who doesn't show up, and then you have an empty slot. So that's not good for patient care. It's not good from a business perspective as well. And so you see here that with telehealth, we had a very low no-show rate. Now this next slide is a little bit harder to see because I apologize that I couldn't get the lines darker. But you now see this data from August. And you'll notice that on this small slide here, that 80% ratio has come down. So now we're seeing closer to 20% of our patients, as things have opened up and we've kind of started to understand this disease, and we understand how masking and distancing can provide a safe in-person environment. Our telehealth rate is pretty consistent, 18 to 20%. And this is also what you're seeing across the country at small and large organizations. And so we'll see, post-pandemic, is this where telehealth is going to lie? Is it going to make up, instead of, 1% of our access points, but closer to 15 to 20% of our access points? That's kind of where I'm thinking things will settle out, but we'll have to wait and see. But you still see, even though telehealth is a lower used modality as compared to total visits, it still keeps a really low no-show rate. And so I think what that tells us is that organizations can strategically use telehealth to keep that no-show rate down. And that's going to help patient care, is going to help their bottom line. So obviously, can't predict the future, but I think this is something to keep our eye on. So I put this slide here, and this is pre-pandemic data that we collected on technology literacy and a really telemedicine training for medical students. We surveyed a number of schools, and among 300 respondents, what you notice here is that all these are on a Likert scale of 1 to 5 are down in the 1 range around, am I learning about how to do telephone appointments? Am I learning how to do two-way video? Am I learning how to use email communication with my patients? Am I learning about remote patient monitoring? And so there's a gap between how we're preparing our doctors pre-pandemic to what we think a post-pandemic environment is going to look like. And so it's an important niche for us to fill in the medical training enterprise around how we make sure that trainees coming out are prepared. But we also have, those physicians who've completed medical training, are in their residencies, or are in practice and have been practicing for a long time. And how do we also meet the needs of their training and education so they can deploy this modality. So I think those are really big issues that are going to face medicine, and there isn't a consensus on how to approach this just yet, but we're reaching that point, or at least reaching that point of consensus that this is a problem and something that we must address. Now, there's also the issue of patients and how do patients adopt technology? What is the level of patient education, patient technology literacy, or what I call digital health literacy among patients? Pre-pandemic, you could build telehealth, and you really did not have a lot of comers. Utilization of telehealth was quite low, and we hadn't figured out how to drive that engagement. And now we'll have to see if we can, ride this crest of engagement with telehealth now into a post-pandemic world. And how do we help make sure we are bridging the digital divide? And in a lot of cases, it's recognizing that that devices are out there in a lot of populations that we don't expect it. In the Medicaid population, even in the more elderly population, that there are pretty reasonable penetration of smart devices, laptops, tablets, and desktop computers. But how do we make sure that people know how to use them, how to leverage them for their health, how to enable self-care, how to enable ownership of their own data? And so this slide just shows you a few pictures from a program we developed last summer pre-pandemic called Health Desk, which was a community and academic partnership modeled after like the Apple Genius Bar, a clean, simple, high-tech, high-touch vehicle to engage the community and say, hey, we're here to help demystify using technology for your health. And if you come and talk to us, we will have peer educators and we'll have people from GW there who can help you, use your own device to maybe set an alarm about when to take your meds, or help you download that patient portal that your doctor has been telling you to do, but you just couldn't figure out. Or even as simple as, helping someone reset their Apple ID password or their Android password, or changing the font size because it's become more difficult for someone to see smaller letters. Those are the level of intervention that we are at today that could be incredibly impactful. So they're very kind of low level interventions, but there hasn't been a lot of focus on helping bridge that gap. So there have definitely been COVID enablers for technology in healthcare. There were a series of emergency waivers, and I mentioned those kind of early on, but there were a lot of them. And telehealth has been mired in a patchwork of regulation, coming with a lot of barriers to adoption from CMS, and then trickling into Medicaid, the private payers, state-by-state licensure issues. So telehealth has been hard to implement because of the challenges in navigating all those regulations. And with these waivers, I think a lot of doctors, one, where they were forced to implement, but now they've learned how to implement. And so we'll see which of those changes are going to be retained and will continue to enable telehealth. Of course, social distancing has been an enabler as well, right? Without social distancing and this requirement to be apart, we may never have actually got to this point. So we'll have to see what happens post-pandemic there. There's just a ton of uncertainty, but we are getting a message from CMS, and this quote, there's absolutely no going back, came from Seema Verma in April, and the CMS so far has not yet kind of helped us get a lot of clarity. There are a number of legislations kind of percolating their way through right now, but there hasn't been the clarity that it would be nice to have so that you could start to plan for 6 months in advance. But I think there will be the persistence of some telehealth waivers. I'll just give you one example. One waiver was that you didn't have to use a HIPAA compliant and secure telemedicine platform. You could just use FaceTime, anything you got, let's just get people connected. And I think that, of course, will not persist. And I'm not sure it should persist. That we do need to have security provisions in place to make sure that people's information is kept private and those consultations are kept private. But we have also seen the waiver of a restriction that if a patient was in their home, that was not a qualified originating site for a telehealth encounter. And I think that's a critical one that needs to persist, because otherwise telehealth dies again. If the patient can't get care from home, there's really no point in going to another facility to then get care, especially in urban areas. Rural areas, there's still some. And so there have been a few executive orders that have continued to advance telehealth in rural areas. But I think we need to keep our eye on urban areas as well, because urban patients face some of the same challenges that rural patients face as well, and that needs to be recognized. I think that we'll enter a new phase of patient experiences and patient expectations. And I think patients are going to expect to have these kind of online options available to them. And so there'll be demand for every practice to offer this. And, pre-pandemic, there was some interest among patients to say, I would probably choose a practice A over practice B if they offered me a telehealth option. But I think we're going to see that number really skyrocket. We're going to see infection control perceptions change. We've kind of lived with the flu as an infection that's out there, but now we're more comfortable with masking in clinical settings, especially. I think we're going to drive some of these infections down. I think we're going to see improved sanitation protocols that are going to continue onwards. And I think that'll extend outside the healthcare system. I think you're going to see, the metro continue to be a more clean environment. You're going to see, Ubers and other types of shared vehicles also continue to have keep those paradigms in place. Healthcare has always been very fragmented, and I think this is going to be an opportunity for us to try to disrupt some of those broken systems, try to take learnings from other industries and really apply them in healthcare, which we've always wanted to do but haven't been as enabled to do. I think we will see that happen. We'll see integration of telehealth and monitoring into broader care now that we've had experience with it. This next bullet here, future of clinician work, I think is a really important one as maybe a physician who's moving jobs or a physician who's coming out of training and joining a new practice. I think you're going to see potentially different expectations of what your contract looks like. What are you going to be asked to do? And you might find that from a work-life balance perspective, young doctors are going to be demanding a practice where one day is telehealth from home instead of 5 days of clinic. And so we're going to have to adapt how we contract with doctors, how we pay doctors to take some of that into account. And then I think it's going to be critical for us to make sure that we use technology for good, that we try to address health disparities, and that we don't increase the digital divide, we don't increase gaps in care, and that there is improved health equity because of all these things. And that's going to be important for us to keep in mind, that these benefits don't just reach the wealthy, but reach all populations. So those are my thoughts. If there's any questions, or we'd love to have dialogue with you all.
Thank you so much, Dr. Sika. That was really, really important information, and very interesting as well. We have a couple of questions. One is from Q&A from the audience, who says, all of these programs and initiatives in response to COVID challenges are very impressive. As the head of the department, how are you able to deploy all of these programs in such a short period of time? And there's another part to that question, but you could answer that part first.
Yeah, so, well, one, I think, was anticipating needs. Deploying from an emergency medicine perspective, we saw a lot of demand reduced within the ED. People were staying home. And so we actually had some excess capacity of people. Now, when you look at the practice, across all specialties, there was that same fall off in overall demand. I mean, we were seeing, 60% reduction in patient visits for some period of time. So we kind of had capacity in that sense. But the challenge was really bringing everyone up to speed, making sure we had the technology in place, making sure we had the infrastructure to support doctors who were new to this, doing all the trainings. And so that's where the countless hours were spent from support teams at all levels within the organization. And you're looking at registration staff, billing and coding staff, IT, informatics, trainers, all of those types of people really had to step up and work together as a team. It was really, I think, an incredible lesson in the teamwork that goes on behind the scenes in all large organizations.
Yeah, teamwork is definitely essential in this time when all businesses are in crisis. To survive, they have to work together. So in that, the next part of that question is, do you have any advice for people who are looking to be entrepreneurs and develop new programs or business lines within their company? I guess specifically in this time.
Yeah, I mean, I think it's important to keep in mind that we will get through this, and so we need to see what's the good we can take from responding to this pandemic that can make either a service or a product or processes within a business better in the long run. I think if we're just looking at like responding to pandemic, that can be somewhat short-sighted. So it's really critical to say, okay, well, if I think I need to implement some type of a procedure today to respond to the pandemic, just put it in context. Where does this go as we climb out of this pandemic? Whether it's 6 months, a year, or a year and a half from now, and how does it benefit the organization?
Thank you. When you talk about bridging the divide, have you seen much resistance in terms of telehealth and telemedicine, whether it's from healthcare providers or patients? So that adds to the challenge of not just bridging the divide, but people being willing to have that actually happen.
Yeah, I mean, there's always in that whole technology adoption paradigm, right? There's kind of the early adopters, and there's the enthusiast people, and then there's kind of the laggards behind. So that happens within medicine as well, both on the patient side and on the physician side or the provider side. So we took a strategy to start with our most enthusiastic adopters, and then let them kind of become the trainers or become the kind of the champion within their own small leadership circle. So let's say you had a department of 5 people and you had somebody who was a real champion, focus your energy on that one person first, and then let them be the, instead of me as an emergency physician trying to encourage an allergist to do something, let that allergist, who was the early adopter, encourage their colleagues to bring things on board. So that, I think we used that strategy. It seemed to work quite effectively. And I think what we found was those people who said, I'm a laggard, I don't want to start this very quickly, were actually pretty fast to say, wait a minute, this seems to be working. It doesn't seem that hard. Bring me on board. I don't want to wait. On the patient side, I think it's a major struggle to help the patient who's far away from you, right? You can't do some of the hands-on technical support that you may want to do, especially when you're dealing with like a variety of devices and a variety of education levels and connectivity and all of those different parameters. And so, we used a number of different strategies to try to assist patients, including allowing them to utilize a phone-only consultation when they couldn't connect on video. And we were fortunate that the waivers from CMS allowed for that to be reimbursed. But we definitely emphasize that patients should use video when at all possible, and that phone was our last resort. But we have to recognize that not all people will be able to connect. So it goes back to that program health desk. What can we do in normal times to continue to improve digital health literacy, so that when people are really forced to use that technology, they're able to do it?
Yeah, and that's definitely when we're not going back, but when we start getting a little bit more semblance of normalcy, this is still going to be so important. So we need to have provisions to have it be to keep going and keep everything functional when we actually get to that point. So yes, and it seems like adaptation is really one of the most important things that you're talking about, being able to adapt and assimilate to a new environment. We have another question from the chat here. In bariatric surgery, our nutritional evaluations and nutritional support groups increased participation by 240% and a no-show rate of less than 5 to 8% overall. Do they find the same results, and in which areas is it most successful? Do you find the same results, I guess, and in which areas is it most successful?
Yeah, I think that's, what our practice-wide data kind of sounds very congruent with that. Honestly, this has been such a fast-moving, issue that we haven't had the chance to go back and do deep dives into smaller areas. The departments themselves are tracking, what's working, what's not working, and trying to, I would say, look at those metrics and see how those programs might be better integrated into the future. But we are still running on this treadmill and haven't had the chance to go do some of those deep dives. Some of the things that are being tried out, though, or being tested within the MFA are things like group visits. And so I think that goes along with some of these counseling sessions, interprofessional counseling sessions where you might bring a nutritionist on, or a diabetes educator with an endocrinologist, like all of those kinds of interdisciplinary and group types of things that really, we were barely dabbling in pre-pandemic are being tried now.
Sorry, I forgot that I was muted. And then what about surgeons? So in this person's bariatric surgery, some are using it, some are refusing to use it. So what are you seeing, I guess, in that?
Yeah, that's a good question. I mean, I think our surgeons were happy to get back to the operating room. They for quite a while, they were, kind of prohibited from doing anything but emergency procedures. And so now that elective surgeries are back on the table, they're excited to be back in the operating room, and we're almost at normal volumes. So where will telehealth persist there? I think that they saw some value in the follow-up care, and even the pre-op care before surgeries. I know one of our ENTs, he was telling me the other day, he just loves how he's able to kind of set up his clinic and kind of pre-op everybody on day one, give them all a very uniform experience, have his teams pull all the data together, and the patient gets a better experience. It's very efficient. They don't come to the office for visit one, oh, I need surgery, and then go collect all this outside data and come back. Okay, now I've reviewed all this data. This is the surgery you're going to do. And then the third time come for surgery. He can do all of that in one online visit and then just schedule them for surgery. So it's an incredibly better experience for the patient. But it does take a lot of resources and coordination and choreography to make it all a good experience. We've been very interested in trying to figure out how post-operative follow-up could be managed through telehealth, because we think that some of the processes there allow us to smooth out for this kind of the digital divide issues and the adoption issues. Because if the patient is already in the hospital, has the procedure, that's the point of intervention. You can say, download this application. This is how you use it. This is how we're going to communicate you. Set all the expectations. And then that post-operative care could occur virtually after the procedure. So that's an area of interest of ours to pursue. We've also been kind of surveying our surgeons to understand what their perceptions of patient interest is and what their future thoughts are on using telehealth post-pandemic. That data is still pending.
Is there a risk of not being sure, I guess, in terms of the kind of surgery that a patient needs, or that they do need surgery through pre-op virtual, I guess, what's the word? Virtual meetings, or it's not the word I'm looking for, but through kind of deciding that by virtual means, is there a risk that it's not what they actually need, the surgery?
Yeah, I think, I think what I would say to that point is that, telehealth is not a panacea for medicine and access, right? I mean, it has to be used with good judgment, has to be used appropriately. There are a variety of tools you can do to get better and better fidelity of your evaluation of that patient, whether it's, a device at home, like a camera or a stethoscope or whatever the case might be for the specific disease, or enabling, sending a nurse to the home to help facilitate an examination, or another healthcare worker, or training a family caregiver to help assist with that evaluation. But if utilizing those procedures to kind of gather the information you need is not adequate, then you're not going to make a decision until you see that person, in the office. So there are some very clear-cut, I think, decision-making that can be made, and there are other areas that you have to recognize that telehealth will be limited, and you have to utilize telehealth as a stepping stone to getting that person into the office to do the appropriate evaluations. And you need to make sure that you scrutinize the quality of the service you provide through telehealth, just like you scrutinize any in-person care. This is just a different modality. It's another tool in your toolbox to being able to give people the care they need at the right time, at the right place, all of those factors that go together in providing kind of high quality, holistic care.
And I guess it seems like there won't be kind of a one size fits all solution in the near future, because there are certainly patients who really want to be, in a person to person conversation with the surgeon or with their doctor in their physical presence, to have that more kind of personal relationship.
Yeah, I think, pre-pandemic, actually going way back, almost 10 years, 2010, 11 or 12, I had been working with this neurosurgeon in New York who was doing some incredible work. And what he would tell me was that he would sit down in person and explain to a patient and their family member that, really bad news, you have a brain tumor. And at the moment he said tumor, everything else he explained in person was lost. And then the patients would go home and they would struggle with, well, now what's going to happen, and not remember, not be able to understand, have a lot of confusion. And so what he was doing was using telehealth at that point to say, look, this is a lot to take. We're gonna follow up virtually and spend more time on understanding this when you're in the right, setting, when you're comfortable, when you've kind of dealt with the shock. And so it's that same, I think, the same type of approach that you can actually build a really great relationship with a patient through video, and sometimes even a more intense or an intimate relationship through video, because there's so many less distractions. There's so much all the noise can be taken away. It's not always the case, but in some scenarios that can be a really powerful tool to build that relationship further and provide the patient the information, the context that they need.
Definitely. And with things like therapy now, we're seeing a lot more people being more comfortable with therapy through telehealth and just being able to communicate that way. I think we have time for maybe one more question. So do you think that we'll see restrictions in telehealth and telemedicine become more restricted or increase after this whole pandemic has kind of subsided a little bit, and it becomes more of the norm? Will we see more restrictions or fewer in terms of how you can practice it?
Yeah, I think, the pandemic related waivers really were enabling. They really lowered, like I mentioned, the security bar on certain technology. So I would like to see there be a really good balance between access for patients and kind of ease of implementation for providers, and expansion of where the patient can be. I think those are really critical ones that'll need to be addressed. And I think that CMS is getting that message. They're seeing all this data. Everyone is advocating for this at all levels, whether it's technology companies, telemedicine organizations, all types of advocacy groups are looking at kind of sending the same message. So I think we're going to move closer to kind of optimal telehealth regulations, but there's also concerns from a legislative side on fraud and abuse and cost and quality and a lot of different factors. So we'll see how all those get weighed together and come out with something that's hopefully really improves care for patients.
Well, thank you so much. I'll pass it back to Dan to close us out, but I can speak on behalf of myself and everyone attending that we really appreciate your time and you sharing this information with us, which is important information for all of us to be aware of.
Thanks for having me. I appreciate it.
Yes, thank you, Dr. Sicca. Thank you, Jamie, for moderating our Q&A session today. Thank you to everybody at ICSB who helped put this together, and thank you to the rest of my group members who helped structure the session for today. But that is all the time that we have, and I'm excited to see where telemedicine will go in the future. So thank you again for joining us. Bye.
Thank you, Dan. Thank you, everybody. Jamie and everybody. Dr. Sika, thank you very much. And we're ending this session, and we're going to start the next session at 2:55. Wonderful job, everybody. Great job. Thank you, everybody.
Thanks. Bye.